Good evening, everyone. I'm Nikhil Bachu from MedWorld Expo. We are from a unified digital healthcare platform called MedWorld Expo. Here we connect you with manufacturers, distributors, hospitals, clinics, labs, and all the healthcare experts worldwide. So it's my pleasure today to welcome Dr. Shravan Kumar Konda, a consultant and head of pediatrics and neonatology at Samraksha Hospital, Siddipet. Dr. Shravan sir holds an MD in pediatrics and brings over 6 years of experience in managing complex neonatology and pediatrics cases, including critical NICU care. He has been actively involved in community health through free medical camps and public awareness articles in Telugu newspapers. Dr. Shravan sir is also a life member of Indian Academy of Pediatrics and regularly participates in national and state conference to stay at front of his field. With his dedication to his child health and community service, we are truly honored to have him with us today. Please join me in welcoming Dr. Shravan Kumar Konda. Sir, the stage is yours. You can just start the session.
Good evening, everybody. Uh, just now, Nikhil has introduced about myself. Uh, so, when he was asking me about webinar, which topic, I thought community acquired pneumonia is a perfect choice because nowadays the season is very high, and almost every home there is a pediatric patient. The reason being, most of the cases are community acquired pneumonia cases. So I thought the topic would be apt for today's discussion. So I will be dealing in these following headings, that is introduction, epidemiology, risk factors, etiology, clinical features, and what are the investigations you do in community acquired pneumonia, and what are the gold standard tests, and when you have to hospitalize a child when he has pneumonia, then what are the latest treatment options and how you are going to prevent these pneumonias. I will be discussing in these headings. So coming to today's topic, that is community acquired pneumonia. So what is pneumonia? Actually, pneumonia is a acute inflammation of the lung parenchyma. If you say lung, in which part of lung, it is especially in the parenchyma. So there are various pneumonias. There are hospital acquired pneumonias and community acquired pneumonias. So when you say community acquired pneumonia, it has to be acquired from the community with droplet infection from other child or other patient. So when a school in the school, if one child gets infected, he can transmit the infection to other child. So if this category comes in, this kind of patients comes in community acquired pneumonia category. If a child gets hospitalized with other problem, and if he gets pneumonia, then it is called hospital acquired pneumonia, that is HAP. Now we are discussing about CAP, that is community acquired pneumonia. So coming to epidemiology, so why we should know community acquired pneumonia means almost 22% of child deaths occur every year because of pneumonia. Till now, almost according to latest data I am reading, till now, 7,40,180 children below 5 years of age has been died till 2019 data. So, which age group usually gets infected means 1 to 5 years of age group children will be affected. So that's why it is important preventable health problem, especially in low and middle income countries like India. So how the incidence of pneumonia usually varies, like depending upon vaccination status, diagnosing criteria. So usually deaths, mortality rates increases when the child gets pneumonia below 2 years, that is first 2 years of life. So this latest information, that is in multi-center study in United States, the annual incidence of hospital admissions due to pneumonia is almost 15 to 16 per 10,000 children. So this is the incidence of pneumonia is very high. So coming to risk factors, what are the risk factors to get pneumonia? So usually the risk factors will be low birth weight, lack of breastfeeding, undernutrition, indoor pollution, parental smoking, and air pollution, overcrowding, incomplete immunization, sometimes like HIV infection and all. Coming to nutritional aspects, malnutrition is the bigger risk factor for pneumonia, and sometimes zinc deficiency, vitamin A deficiency, all vitamin D deficiency. These are the nutritional aspects. And sometimes if the child is going to daycare, or if his age is very less, below 2 years and below 3 years, if they are sending to school or Anganwadi center, the morbidity of respiratory infection is very high in these kind of children. Coming to uh, etiology, usually pneumonia, there are various organisms like viruses and bacteria. Most commonly, you see bacterial infections like Streptococcus pneumonia and Haemophilus influenza B and Moraxella catarrhalis. So these are the main organisms. Sometimes you can see Staphylococcus pneumonia also, but the incidence is very less. Usually, we come across most common pneumonias are Streptococcus pneumonias. So these Streptococcus pneumonia, in recent years, the etiology of Streptococcus pneumonia in hospitalized children is very high. Sometimes last year we have seen so many cases of chlamydia and mycoplasma infections. This comes under atypical pneumonia. If you see it according to age group, newborns usually we see enterobacteria, that is gram-negative bacteria, and group B streptococcus. Coming to infant age group, you see various viruses and viruses like RSV and para-influenza and influenza group. Bacteria, Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis, Staph aureus, Chlamydia, and Bordetella. Less than 5 years, again the same, all these same organisms, but Mycoplasma pneumonia also we are seeing in less than 5 year children. More than 5 year children, this chlamydia comes into the higher incidence. Mycoplasma pneumonia and chlamydia will be more in more than 5 year age group. Viruses like RSV and rhinoviruses are most common viral pathogens in community acquired pneumonia. Coming to clinical features, as you all know, the clinical features will be most common signs and symptoms are fever, cough, tachypnea, breathlessness, chest pain, and sometimes low-grade fever and high fever, vomiting, malaise, myalgias. All these symptoms will be there. Headache. Sometimes, if you with examination, you will be seeing crackles or crepitations, decreased breath sounds if it is a consolidation, and bronchial breath sounds may be present in lung auscultations. Normal auscultation finding do not rule out pneumonia. If I say normal auscultation finding, it means that it is not there is no pneumonia. Sometimes normal auscultation findings will also have pneumonia. And the presence of hypoxia, if you check the oxygen saturation of the patient, if he is hypoxic and if he is tachypnic, it means it comes under severe pneumonia. So WHO, what it recommends? WHO says that tachypnea and retractions both are enough to diagnose pneumonia. So while children with tachypnea were classified as pneumonia, who had retractions, they will be classified under severe pneumonia. So these two things, I want each and everyone who are attending this class, take home message will be these two things. One is tachypnea. Always, if you are taking consultation fees for a patient, at least spend 1 minute for counting respiratory rate. That is where the what you can say good doctor who can see the respiratory rate is a good doctor. Hmm? If you know the normal respiratory rate according to age group, compare with the patient respiratory rate. If it is high, means there is some problem in the chest, whether it is pneumonia or it can be any other thing, bronchiolitis, or it can be some other thing, heart related problem or chest related problem or airways related problem, anything. So take home message will be, if there is high respiratory rate, tachypnea, then it could be classified as pneumonia. Tachypnea with retractions, it could be classified as severe pneumonia. Okay. And what are the danger signs when you should be worried? Danger signs will be lethargy, respiratory distress, apnea, if the child is holding breath, toxic look, and dehydration, seizures, cyanosis, then the child is very, very sick and you have to admit him into the PICU and he will be requiring life support or any other advanced support in the form of AirO2 or any ventilators. Hmm? So coming to lab tests, so usually lab tests will be WBC count and absolute neutrophil count and C-reactive protein and erythrocyte ESR. Usually these are only supportive, but the diagnostic test will be, the effective test you can say will be procalcitonin. It will be helpful in guiding the treatment. Imaging techniques, usually we perform chest X-rays bedside. Sometimes we will perform CT, but that is not a first line imaging tool for the diagnosis. When we have to do CT means, if you are suspecting necrotizing pneumonia or very severe pneumonia or some other underlying pathology you want to rule out, then you have to do CT scan. So the guideline says that chest X-ray, usually it shows alveolar infiltrates, more suggestive of community acquired pneumonia. While the interstitial infiltrates, if you are seeing, then it is suggestive of viral or atypical organisms. So these two things. Sometimes chest X-ray, it is very difficult to differentiate between viral and bacterial pathogen. But lateral X-rays, we can differentiate, but this is very difficult to perform in the pediatric age group, lateral X-rays. But nowadays, lung ultrasound is usually ultrasound. There are many are doing lung ultrasounds for to improve the accuracy compared to X-ray. But lung ultrasound versus X-ray, if you could see the comparison, the almost both are above 95% in diagnosing the pneumonia. So whichever is easy and convenient, do those investigations. You can go for lung ultrasound or chest X-ray. But ultrasound is time taking. Sometimes the patient will not be cooperative. X-ray is easy and it will give you immediate results. But CT is done only when you are suspecting or whenever you want to differentiate the pneumonia from other diseases. If you are suspecting interstitial pneumonia, then it has to be get confirmed by CT scan only. So microbiological tests, usually microbiological tests like to know the organism. Like if you want to know which organism has caused pneumonia in this child, for that these microbiological tests will be helpful, like a gram stain and culture, usually performed for sputum in elderly children and adolescents, and throat and nasopharyngeal aspirates or induced sputum sampling. You can give hypertonic saline nebulization, and you can induce the patient to remove the sputum, and you can send that test to lab for to know the which organism is causing the pneumonia. Usually, many organisms colonize the upper respiratory tract, but the results should be considered when you are evaluating the pneumonia. Blood culture is used for bacterial pathogens, but the positivity rate is very, very low, that is below 10%. And you can increase up to sensitivity up to 30% by taking adequate sample and the culture you report, you have to wait for 7 days. But bronchoalveolar lavage, this is recommended only in hospitalized patients and uh, which has higher positivity rates, but it is not available everywhere in tier 2 and tier 3 places. Sometimes PCR, it is also again gold standard test, but it is very costly and not affordable. The PCR is usually performed with sputum or nasopharyngeal secretions. Serological testing, what it will give is the organism, that's what I said. So coming to management aspects, so after the child has been diagnosed with pneumonia, primarily the treating pediatrician should decide whether this child requires hospitalization or whether he can be managed at home or not. So to decide this, he has to categorize which pneumonia it is, whether it is severe pneumonia or normal pneumonia. If you are saying it as severe pneumonia, then you have to admit him, and you have to look for complications like pleural effusion or necrotizing pneumonia or lung abscess. And if you are sending the child with oral treatment, oral antibiotics, and you have to ask the child to come back again after 48 hours, then you have to re-examine and look for whether he is progressing to severe pneumonia or he is improving. If he is improving, then he has to continue the treatment for at least 5 to 7 days. If he is not improving, then you have to categorize him into severe pneumonia, and you have to get admit him to the hospital, and you have to monitor the child. So what you have to monitor, you have to see the all vital parameters, chest indrawing and radiographic changes. And important sign, you have to see the SpO2. If it is below 90% in the ambient air or impaired consciousness, confusion, unresponsiveness to painful stimulus, then he is going to respiratory failure. Then you have to think of um, upgrading the life support, like giving him mechanical ventilation or NRM mask or AO2, and maintain IV, correct his dehydration. So general management of pneumonia will be antipyretics and IV fluids, oxygen supplementation, if required, ventilation support. Sometimes some people will perform chest physiotherapy, but new data says that chest physiotherapy is not that much effective. But no beneficial effects or no reliable conclusions on chest physiotherapy. Recent data says that. So treatment decision in children with community acquired pneumonia made according to the age, clinical, laboratory, and radiological findings. If the child is below 5 years, various guidelines recommend that amoxicillin is the first line in the treatment of OPD settings. outpatient for previously healthy and appropriately vaccinated child. Sometimes macrolides are recommended as first line if the child is allergic to penicillin. Mycoplasma pneumonia and chlamydia are suspected pathogens in school-age children and adolescents. In those settings, macrolides will be first line of choice. So many will be worried, sir, how many days we have to use how many days of antibiotics we have to take. The recommendation is 7 to 10 days. There is a data recently published. It says that short course versus long course, 3 days versus 5 days. Which course is better, 3 days or 5 days? This data says that almost 5 to 9 days course is better than long course. So there is no 3 days. You have to use at least 5 days. And this is the message also I want to give. Many are giving antibiotics for 3 days, 2 days, 1 day. That is not good practice. Okay. You have to give short course means 5 days, at least 5 days. If you are writing your prescription for standard course, it means that 10 days. Don't write prescriptions like 3 days, 1 day, 2 day. Huh? Now, what I am saying is almost 10 years data, meta-analysis conducted that is safer short course antimicrobial therapy for pediatric respiratory infections. That is safer data and scout cap data. What I am reading is these two data says that you have to give short course means 5 days, standard course means 10 days. Don't give 3 days from now onwards. So if you are suspecting macrolide, if you are suspecting mycoplasma pneumonia and chlamydia, in those situations, you have to use macrolides, what I have said just now. Sometimes staph aureus also, if you are seeing staph aureus, then it is necrotizing pneumonia. In those situations, you have to take vancomycin and clindamycin. Okay. Again, the duration of days will be 10 days or 10 to 14 days. If it is very severe pneumonia, you have to give it for 14 days. Once the child is receiving antibiotics, you have to assess the following things, whether he is improving or not improving. Improving means there should be increase in the activity and there should be increase in the appetite and his SpO2 levels should be more than 90 to 92%, and there should not be any fever for at least 12 to 24 hours. So in the evaluation, if the child 48 to 72 hours after treatment, still he is persisting fever and there is no clinical response, what you will do? You have to label him as treatment failure. He has not responded to your treatment. Then you have to look for presence of any resistant microorganisms or whether he is developing any complications like pleural effusion, empyema, pneumatoceles, or necrotizing pneumonia, lung abscess. Sometimes there will not be any complication, but the child may be immunosuppressed child, or whether he is suffering from other concomitant disease. Like sometimes he may be having a UTI. In the routine evaluation, you have missed the UTI or some other things. If he has admitted for pneumonia, he developed gastroenteritis. Then he is having the fever. So all these things you have to keep in the mind. So coming to prevention, how you will prevent this pneumonia? Despite widespread vaccination policies, community acquired pneumonia is still one of the most important preventable infections in the children. So how do you prevent? One thing, you have to educate each and every mother and each and every parent. And nutrition. If you see pneumonia patients, many will be malnourished. Many will not be appropriate for their weight will not be appropriate for the age, and height will not be appropriate for the age. And the importance of breast milk and hand washing, improvement of crowded living conditions, prevention of smoking, vaccination. These are the main primary policies of preventing pneumonias. And annual influenza vaccinations, which will be recommended in all children, those who are above 6 months, especially in high risk group. And also sometimes specific monoclonal antibody will be giving in RSV outbreak, but this is available only in Tier 1 cities. So the vaccination with pneumococcal conjugate vaccine and HIB has been recently become widespread and many are taking. Coming to which vaccine I should take, whether I should take PCV10 or whether I should take PCV13. And there is data conducted in more than 150 countries. It says that PCV13 is the best standard vaccine available and they have to take. But in India, many vaccination last 2-3 years, many has underwent vaccination for PCV and many has taken 10-valent vaccine. So those who have taken 10-valent vaccine, again they are turning it as pneumonia patients. Is it useful? Recently, the government understood this and they have changed this PCV10 to PCV14 valent for latest for 2024. Those who are taking 2024 born, those are receiving PCV 14 valent vaccination. That is Nubivax 14. So coming the most resistant pneumococcus strains, that is 23F6A, 6B, 9V, and 19A, 19F, 14. These all are included in PCV13. That's why whenever you are receiving vaccination, always ask the treating pediatrician that which vaccine I am taking, whether it is PCV 13-valent vaccine or 10-valent vaccine. So pneumococcal conjugate vaccine association has been independent association in reducing the frequency of hospitalization compared to no vaccine. So, okay, thank you.
Thank you so much, sir. Sir, actually, we have few questions in chat box. So let us go with the questions and then we can wrap the session.
Okay.
So first question is from Venkat Sohan. Hello, doctor. Could you explain how community acquired pneumonia differs from hospital acquired pneumonia?
So hospital acquired pneumonia usually occurs in a normal child who has been admitted in the hospital. It's usually nosocomial infection. The child is normal. He has admitted to the hospital with some other problem, but he developed pneumonia in the hospital. This is called hospital acquired pneumonia. In this, the organism will be different. Whatever we have discussed, the organisms like Streptococcus pneumonia, Staph aureus, Moraxella, Catarrhalis, Haemophilus influenza. These three organisms will not be the causative agents in the hospital acquired pneumonia. Here, in community acquired pneumonia, these are the causative agents.
Okay, sir.
Next question.
And we have a question from Pawan Kalyan. Sir, what are the standard first line antibiotic recommended for CAP treatment, CAP treatment?
Amoxicillin. The textbook says amoxicillin, but if you go to any pediatrician in this India, nobody will write amoxicillin because amoxicillin is textbook says first line, but here it is not available everywhere. Amoxicillin. We are writing amoxiclav. You can consider it as amoxiclav is the first line antibiotic recommended for CAP treatment on OPD basis. Like if you are admitting the child, again the ceftriaxone, penicillins, you can call it as a wide group of penicillins.
Got it, sir. And we have a question from Aisha. Sir, what are the most common germs that usually cause CAP?
The same thing again, the Streptococcus pneumoniae, Haemophilus influenza, uh, Moraxella catarrhalis, Staph aureus, Chlamydia, Bordetella pertussis, Mycoplasma pneumonia, Chlamydia trachomatis, and respiratory syncytial viruses, rhinovirus, But the outbreak, what we are seeing nowadays in everywhere is influenza A and influenza B. Sometimes you see adenovirus also. These are the outbreaks.
Okay, sir. And one last question we have from Pawan. It is also related to CAP. Doctor, may I ask which group of people are more prone to serve this CAP?
Severe cap. He is asking
Yeah, severe
severe.
CAP.
See, good question. This is very good question. He is asking whether which category of patients will go to severe community acquired pneumonia.
Yes.
Like usually, we see in malnutrition, whoever the child whose weight is very less, like compared if he has to be 10 kg, he is 6 kg, 5 kg. The chance of going to severe pneumonia is very high among them. And the bottle fed children, those who are not breastfed. So all these children, they can go to severe pneumonia, like vitamin A deficiency, zinc deficiency, D deficiency. Hmm.
And we got another question, sir, just now from Akshay. Could you please share the early warning signs of CAP that families should look it out?
Early warning signs is if the child is having high grade fever, more than 1 or 2, 1 or 3, for more than 2 days duration, and he is rapid breathing. He's not taking any feeds or he's not drinking milk, and lethargy, he's drowsy, continuously sleeping, huh? Mm, vomiting, whatever he is eating, vomiting. These are the early warning signs.
Okay, sir. So that's all we have in the chat box, sir. I think you have answered their questions.
Mm,
Before we wrap this session, I just need to take 2 minutes of time and explain about MedWorld Expo, and then we can wrap the session, sir.
okay.
Yeah, I'll show. Let me present my screen. I hope you can see my screen, sir. Yeah.
Yeah.
So good evening, everyone. Thank you for being active participant today. I'm going to talk about MedWorld Expo, which made this session happen till now. So MedWorld Expo is a global healthcare networking platform where you can connect with manufacturers, distributors, and healthcare services like doctors, hospitals, clinics, any kind of healthcare related professionals. So let me take you through in the process of where most of the audience in the Zoom meeting is related to hospitals, doctors, and medical students, right?
Two
So
minutes.
I will go through the complete platform. What would be the major benefits for you people as in the if you enroll in the MedWorld Expo platform? So first thing, once you open MedWorld Expo, you can just see the landing page. From here, you will be able to log in. So once you log in, if you come into events, you will be able to find out the webinars option. So if you go to webinars, you will be able to see the screen like this. So you can apply for any kind of webinars in particular categories or specialities. So everything is completely free of cost. No webinar is chargeable. Every webinar is completely free. How the way you have joined this webinar in the same way, you can apply for the upcoming webinars also. We have into psychiatry, psychology, hematology, this kind of different specialties are upcoming webinars. So please do apply or register for this upcoming webinars. And we have CME programs which we are going to start in the next month. So most of the doctors look for CME programs where they can renew their license using these credit points. I hope, sir, you are well aware about these things. So
Yes.
CME programs is a credit-based program which we are going to offer from next month. So you can participate in this and you will be able to get credits and you can renew those credit points for the renewal of any kind of business, healthcare licenses. So that is also one big thing that we are going to do. So please do join MedWorld Expo. And next thing, we have news and insights. So as you're into healthcare industry, we have to be ready with complete latest news and trends. What is the medical equipment is coming up with new technology and what is going around the world. So you have to be updated, right? So MedWorld Expo, all the things and all the news and insights were up to date. So you can directly browse and you can understand, you can learn and be on the light track about the latest advancements and the technologies. And we have MedWorld blog page. As a medical student or as a doctor or as any kind of healthcare professional, you will be able to write any kind of medical blogs in this way. So if you can see, we have n number of blogs already over here. So it has been written by practicing doctors, some of them are students. So it's up to you. If you wanted to write, just log into MedWorld Expo and write a blog directly and you can post it. So you'll be able to see the blogs like this. So people who are referring to the particular topic, they might be, this might be very helpful for them. And I request Shravan sir, if you're okay with with it, please do write one blog over here so that people can directly able to see this and they will be learning a lot from you.
Okay.
Yeah. And we have healthcare communities and journals. In the medical communities, as you're into healthcare, you need a good network around across the globe, right? So MedWorld is very specialized in this particular thing where you will be able to find different kind of community groups based on the specialty or based on the interest. So you can create your own community or you can join different communities and where you can network with wide range of people across the globe. So this is one of the opportunity that we're giving for you. And we have journals and magazines where you will be able to access different kind of healthcare magazines and journals, so it will help you to understand and see what all the things are going on across the group. And we have job platform. If you wanted to access different kind of jobs within the healthcare, you'll be able to access these kind of jobs. So that's all about the MedWorld Expo. So thank you so much, sir, and thank you so much for your time. And the session was really very insightful, and people are actively listening to it. And I'm very glad everybody stayed till last because it was very informative. Thank you so much for your time. Before we close, do you wanted to have any closing statements, sir?
I want to give one statement that you give a suggestion to each and every child get vaccinated with latest advanced PCV vaccination.
Yes, sir.
Even though they have missed in their immunization schedule, they have to receive the latest vaccination. And those who have already suffered, they also, after vaccination, they are not getting the disease again. Those who have suffered also, they can also take, and those who have missed also, they can also take the vaccination.
Sure, sir. Sure, sir.
Okay. Right.
Yeah. We have almost 100 participants. Maybe they will be conveying it to other 100 people. So it will be very good informating for all of them. And really, sir, it was very glad to meet you. And thank you so much for acceptance and giving the webinar on time.
Okay. Thank you.
Thank you, sir.
Thank you.
I hope we
Thank
will be
you.
doing other few more webinars on this kind of topics. So it will be very educating for most of the people.
Okay. Definitely. Thank you.
Thank you, sir. Thank you so much for your time. Everybody, thank you. Have a good day, everyone.